Hi, everybody. My name is Leia. I'm on the Sexual and Gender-Based Violence Committee at PHR, and we are here with our second seminar for the series. I'm going to introduce our speaker today. This is Dr. Erin Holtz, who is working at the International Medicine Clinic at Harborview Medical Center. She's a clinical associate professor at the University of Washington, and she's going to give her talk today on trauma-informed care, and I'll let her take it away.
All right, thanks, Leia, and thanks for inviting me. I'm happy to share with you. And before I share my screen, just wanted to let you know this is pretty informal. I'm happy to take questions at any time if you just want to jump in or interrupt. That's totally fine. I'm hoping this can be more interactive and yeah, just that you have freedom to ask questions whenever you want. So let me share my slides. Okay, can everyone see that okay? Okay, all right, great. So, as Leia said, one of my jobs is, or my title, I guess, is a clinical associate professor at the UW here in Seattle. But some of my other roles are working as a clinic education director. So I work with residents closely in the internal medicine residency program. And then I do primary care for immigrants and refugees in the International Medicine Clinic, and then also do some asylum work with a grant. Taking care of survivors of torture. So just the usual housekeeping things. Just want to say I have no financial disclosures. I do want to give a trigger warning, as you can imagine, since we're talking about trauma-informed care. I'm going to go through some cases, and then I also have a video of a patient who wanted to share his experience with trauma. The clinical case that I'm going to present is fictional, but based on patients that we have seen in our clinic. So the objectives for this talk are really to cover trauma-informed care. And there's really the four main tenets of it, the 4 R's as they call it. So to realize the impact of trauma on a patient's medical care, to recognize the signs and symptoms of trauma, to respond to that, to respond to the knowledge of a trauma by having appropriate policies and procedures in place, and namely to resist re-traumatization in the medical setting. So I'll start with the clinical case. So this is HL. He is a 75-year-old Vietnamese-speaking man. And he has a history of depression, chronic back pain, chronic headaches, and he gets admitted to the hospital where you're on the internal medicine service, where he's admitted, even though he has a hip fracture, but he has other complex medical issues. And he seems resistant to care. He refuses a lot of blood draws when phlebotomy comes. He doesn't want to get imaging. He refuses to work with physical therapy. And when he's ready for discharge, his team recommends that he gets discharged to a skilled nursing facility, but he refuses discharge. So we're going to talk through this case through the remainder of the presentation and going through those objectives. So objective number 1, realizing the impact of trauma. So as you know, it's no secret, trauma is widespread. And in the medical setting, no matter which field you go into, you're going to be working with a lot of patients who have suffered trauma. And trauma is more than just the event or the traumatic thing that happened, but there's the event that happens, a person's experience of it, and then the lasting effects. For example, one single event, like for example, a war, people can be affected by that in different ways. So we have refugees in our clinic who have fled the same war. And for one of them who, maybe they fled with their family, who kind of sheltered them, protected them, they all went together. They had a very, smooth journey as far as resettlement goes. They will have a very different experience and lasting effects of that trauma than, say, another patient who is escaping the same war, but maybe got separated from their family, or lost family members, saw a lot of violence or saw death. And then had a difficult resettlement. So same event can lead to very different experiences. So just some brief numbers just on how widespread trauma is. It said 1 in 4 girls and 1 in 6 boys will be sexually abused before age 18. And 18% of women, 1.4% of men in the US will be raped in their lifetime. And then high rates of PTSD this is just one example for Vietnam veterans, so 30.9% for men, 26.9% for women. And then among immigrants, so the population I work with, there's a really high rate of torture for immigrants, particularly refugees and asylum seekers. So I'll talk a little bit more about that, the torture as a subset of a trauma, since that's a lot of what we deal with in our clinic. But torture is defined by the World Medical Association in the Declaration of Tokyo as the deliberate, systematic, or wanton infliction of physical or mental suffering by one or more persons acting alone or on the orders of any authority to force another person to yield information, to make a confession, or for any other reason. And the things I want to draw your attention to really are that torture is a deliberate act, and it's done by someone in a position of power. So this is sometimes a government agent, or police, or military, or in places where there's no functioning government. It can be something like gangs, or whoever is in charge in a stateless place. And rarely is torture done to yield a confession, as this says, but usually it's done more to show, to make an example of people, and to suppress a whole group of people, and to maintain power from an unstable regime. So why we care about this? Torture is hugely prevalent. So in the world, nearly half of the world's nations are known to systemically, I guess, practice torture. And numbers are really hard to get for torture survivors in the US, as you can imagine. But in 2015, it was estimated that there were 1.3 million torture surviving refugees. And then studies are somewhat limited in the prevalence, but here in Seattle, we work with a lot of these populations, refugee populations, as listed below. And so it's pretty shocking to think, that over half of the Oromo patients that I see have experienced torture. It's estimated 36% of Somalis, 54% Cambodian, 56% Iraqi, and 78% Karen. So why this matters, this is a talk for another time, but I know all of you, just by your involvement with PHR, are well aware of the implications of a history of torture and trafficking, just the legal implications for seeking asylum. And as you know, asylum seekers need to prove in immigration court that they have a fear of persecution on the basis of race, religion, nationality, political opinion, or membership in a particular social group, and their history of torture can go toward supporting their immigration case. So the next objective that I wanted to cover was recognizing the signs and symptoms of trauma. So one common symptom of trauma is chronic pain, or in chronic, what I kind of term non-anatomic pain. So it's estimated that, or in one study, 78% of people who suffered, in this case, torture, reported chronic pain in multiple areas of the body, with some common ones being chronic headaches and chronic back pain. And then the quote non-anatomic pain, in medical school, I know there's people still in the preclinical years on this call, and so you can tell me probably more than I remember about anatomy and physiology and dermatomes, but sometimes patients who have survived trauma and torture, the pain that they have doesn't fit with our expected biomedical understanding of what nerve roots should be affected, or what things should be connected, and that's because their physical symptoms and connections are created by their torture experiences. We have one patient in our clinic that my colleague took care of for many years with unexplained leg pain, and his leg pain worsened when he was tired or when he was hungry. And he had extensive workups, including seeing neurology and physical medicine and rehab, and lots of testing. I think probably saw orthopedics, and nobody could figure out why his legs were hurting and why they were triggered by those factors. But it only came out years later that he had suffered torture during the Vietnam War under communist regime, where he was held in solitary confinement and his legs were shackled, and the guards, to keep him awake and torture him, would pull on the chains around his legs whenever he'd fall asleep. And so he kind of those torture symptoms were connected for him: the insomnia and the leg pain and the hunger. So, knowing someone's history can make these things that maybe is easy to dismiss as not making sense, it can make a lot of sense. So other things to recognize, or other red flags that there may be a trauma or torture history, is non-adherence. So this is a quote from a torture survivor from Uganda. And he said, "When I came to the United States in the early 1980s, my nightmares got worse. The hospital setting brought back bad memories, and it was difficult to tell people what had gone wrong, what had really gone wrong with me. The doctors never asked questions about the source of my nightmares, but gave me medication anyway. Eventually, I did not take the medications prescribed." And this is just one example for medication non-adherence, but this can really come up in a lot of other ways. So non-adherence to, not following through with treatment plans for therapies, physical therapy, occupational therapy, not following through on imaging studies, things that may have some roots to their trauma or torture history. And then, of course, there's the psychiatric symptoms of trauma. So a high degree of suspicion in if you're seeing someone with depression, PTSD, and anxiety, it's reasonable to wonder, if there was something in the past that triggered all of these. So high-risk populations include refugees and asylum seekers, of course, veterans also, those who are incarcerated, the disabled, and LGBTQ populations. And so if we go back to our clinical case, looking at, the red flags, or the ways we might recognize symptoms of trauma. So he's 75-year-old man from Vietnam. So already we're thinking, what experiences has he had that led him to leave his home country and then end up resettling in the US. He has a history of depression, so another red flag. And then the chronic pain that he had chronic back pain, and I think maybe chronic headaches. I don't recall exactly, but those are also red flags. And then this non-adherence. So this comes up all the time in the hospital. People are refusing this or that. And it's not always due to trauma, but it's definitely a red flag when you see a patient who is going against what you think is in their best interests and their best for their medical care, to wonder, what is it that's making them refuse all of these things that could help them? All right, so the next R, the third R, is responding. So once your radar is up and you're wondering, is there a history of trauma? How do we respond to this? So number one, I think, really is to give control back to patients as much as you can. It's really hard in the medical setting. A lot of times there's time crunches, there's privacy issues, shared patient rooms. It can be very hard, and patients feel very vulnerable. And so sometimes even just stating, to a patient, everything you tell me is confidential unless there's a safety concern. Whether to have a companion or for the patient or not, or have a chaperone, I think there's no right or wrong. There's a lot of listening to the patient cues and seeing what their preference is. If you think, I do a lot of female genital cutting evaluations in my clinic. And so I'll always offer, would you be more comfortable with if we had a nurse in here also, or would that make you less comfortable? And so just giving them some control about in the situation where they feel very powerless. Positioning and for comfort, preparing them, letting them know what you're about to do before you do it, and asking permission. All sound like very simple things, but I'm sure all of you have seen cases on the wards or in clinic where this is not done, where people just kind of come at a patient and start doing things to them before explaining what's going on. So another way to respond is just knowing when to ask or when not to ask. Again, there's no right or wrong, and a lot is watching for patient cues. So some patients are very open and wanting to talk about their trauma history, and some are very not interested, and that can be re-traumatizing to pry into that. And so sometimes just that awareness and just kind of sensing where they're coming from can be helpful. Paying attention to their social history and knowing how to ask about their support systems and their things that help them or things that make their life harder are kind of roundabout ways to ask when you're asking about their social situation. And when in doubt, to assume that some trauma has occurred. And I think of this like we think about universal precautions. Like we don't check to see if someone has infections before we put on our gloves. We just assume. And it's the same for patients, and particularly in the hospital, to just assume that some trauma has occurred and to approach them as if there was something in their background, whether they've disclosed it or not. So a lot of times what people really want to know, or people ask me about, is like, so how do you ask? Like we know there might be something, but how do you actually ask them? The first one here is probably the one that I think is the most useful in the general kind of wards or inpatient setting, because it gives people an out. So to ask them, a lot of people have experienced trauma and that affects the way they want to receive care. Has that happened to you? And that gives them a way easily to say no, if they really don't want to get into it, or they can open up and say, yeah, I really don't like when people do X, Y, Z. And sometimes we can't help that. And, in the hospital, you're going to have people coming in to your room and things like that. But when possible, to accommodate. In our clinic, doing asylum evaluations, we ask about people's scars in detail. We don't necessarily do this just in routine care because we don't want to trigger people and make them go into something if it's not clinically relevant. Again, asking what someone's nightmares about. This is more in the context, I think, of in primary care and wanting to help somebody if they have PTSD and you're trying to treat that. It's not something I would necessarily ask on the inpatient setting. For a patient I'm just going to see once or twice. And then as far as for our primary care patients, so people we're going to see over and over and over again, and I'm going to get to know for many, many years, it's helpful at some point for me to ask them, where were you born? Where did you go from there? And what made you leave your country? And what was your journey from where you started to end up here in Seattle, where you are? And that can give me a lot of clues along the way. Some people escaped all of the even some of my Cambodian patients say, no, I made it out of there without suffering under the Khmer Rouge. And that's great. And others will tell me, no, I started in Cambodia and then this happened. And then I went to a refugee camp in Thailand and then I went here, then I came to the US. And so as part of the social history, it can come up somewhat more organically than just asking like, have you been traumatized or have you been tortured or something like that? All right, so back to our clinical case. So our 75-year-old man. So you as a medical student, go and spend more time with him before rounds and find out, when you're asking him about his experiences and what's going on with his care. He says that, well, he was in a re-education camp in Vietnam under the communist regime for 22 years. And 19 of them were in solitary confinement. And so and because of this, to him, the thought of going somewhere like a nursing home where he is not, he's not living in his own home, he's under the power of other people, feels a lot like going back to a re-education camp. And so, this gives you more insight into why he might be refusing some of the care that he is. All right, so what to do about it? We see people a lot after these terrible things have happened. And so the last thing we want to do is re-traumatize them. We want to move in the other direction, in the direction of healing. So what can we do to prevent re-traumatization? Like I mentioned, it's really traumatic for people in the hospital, even people who haven't been traumatized in the past. It can be very scary. There's a big power differential as a patient, as opposed to being, in charge. The team, the medical team is in charge, and you just can sometimes feel very, very powerless. There's procedures that are done to people, administration of drugs. And this, in some places, can feel a lot like their torture history. In some countries, torture is performed or supervised by physicians. And so, for example, one of the patients I saw probably 10 years ago or so, she had fled from China because under the one-child policy, when she had been found to be pregnant with her second child, was forced to have an abortion and forced to have an IUD placed. And so for her coming back into the medical setting, you can imagine how traumatic that is. And so if we know this history and if, we elicit this history, when I later had to refer her to the OB-GYNs because she wanted to get her IUD removed, knowing this, and I could let them know her history, went a long way toward preventing her from being re-traumatized by that setting. Other things we do to people in the hospital all the time can be very triggering. So I just put a few pictorial examples, like, for people who've been in positional torture, or, one of our patients in, I think I mentioned earlier, the Vietnamese man, when he was in solitary confinement, he was put in a cell that was it was basically a box. It was too small to stand in completely and too small to fully lie down in for years. And so you can imagine if someone like that, if you had to send them into an MRI scanner, I don't know if any of you have ever had an MRI, but it's a pretty tight quarters and very loud, and it can be very scary and triggering for people. And especially if there's a language barrier and you don't understand what's being said. Another one I wanted to bring up is the issue of dieting or being NPO. This happens all the time in the hospital. So one of my longstanding clinic patients, a Cambodian lady, she had poorly controlled diabetes. And I talked to her about, okay, well, we got to, let's get this under control. We'll start this medicine, but I also want you to work on exercising and dieting and losing a little bit of weight, and that will help with your diabetes. And she later told me actually that was very, it brought back a lot of memories for her. Whenever she tries to diet or restrict her food intake, it reminds her of her experience under the Khmer Rouge when she actually lost some of her children to starvation. Like, she had to watch some of them die. And so for her, just the idea of restricting food was really difficult. And that's not to say that we can't talk to patients in that setting about weight loss or diet or exercise, but knowing their history, there's ways to go about it, and maybe focus more on exercise and in different foods rather than in less foods or things like that to prevent them from being re-traumatized. In the hospital, we make people NPO, as you know, all the time. NPO at the drop of a hat, just in case they need their procedure. Oh, it might happen tomorrow, and then it gets canceled, and we make them NPO again the next day, and then the next day. And that can be really hard for people who have suffered trauma, just another sense of their control or their power being taken away. Did someone have a question?
Yes, sorry. What's NPO?
Oh, I'm sorry. In not being able to eat. What does I can't remember what that stands for. Nil per os or something like that. But basically, no food or drink. And so if someone's having, yeah, this happens all the time. If we think they might go to surgery the next morning, NPO past midnight, and then it gets delayed and
like for surgery or something. Okay, understood. Thank you.
Yeah, sorry. Oops. Okay. So let me exit this for a minute because I'm going to show a video of another patient of ours, and he's going to tell his story in a little more detail than, this isn't something we would, to a level of detail that I would ask about just in a regular clinical scenario, but he wanted to explain to us and he wanted to actually share his story with trainees, medical students, residents, to understand some of what he went through. So he is Cambodian. He was under the Khmer Rouge and suffered torture there, and then resettled here in the US, and has been here and doing pretty well for decades, but then started to have health problems, diabetes, chronic kidney disease. All right, so let me see if I can pull this up.
When you first relocated here, did you have trouble with to the past, or did it always stay with you?
The whole sometimes chung cá mình về mình chữ nhưng mà số luôn đấy nhưng về tôi sắp từ chung cá tôi đi bài miền bài tôi chung cá tôi sắp thì đánh chuẩn bị và đóng tiền đây.
So when you started, let me just rephrase that again, because I think that's important, that when you were starting to get sick with the kidney failure or with diabetes, which was it that you began to sort of start remembering the past again and it came up for you?
Yeah, tôi trong kỳ hào thả đi chiêm máu về tập thầy ghé trả đi cho xong
Tăng pi cái prata rong nông nông khâu cho trời liên chiêm cọ rồi
nhưng đây là ba này cả nó.
Yeah.
Did it affect you in other ways? Did you feel more sad, less energy, anything else that affect your relationship?
Từng on lắm.
Nhưng bên đó nhưng chắc tôi đi nhưng nó slap lại ở đưa ra con tự nhiên đấy chọc lại thì vẫn nhưng nó
How was that like the Khmer Rouge times? How is that similar?
bên nó sự cầm tôi chỉ là cái tốt có sự cầm ta dùng slap lại ngày nào mới dùng slap lại hay ở đâu ní bên con tự nhiên nó còn mà toàn bạn tự nhiên chiêm nó cho nênเคยแต่มึงเหมือนกันแบบสบายcho mà hay hay xong doctor tôi đi sập mai chụp bom phun đó doctor ta phải trồng đo này tới màu bình ba này rồi trồng em lấy che sập hay gì đó đi dùng là
You know what I don't remember.
Okay. So one of the things I think that's most interesting about him is, his experience of torture, forced labor and starvation, and witnessing the murder of his friends, was that he kind of put it behind him and moved on. And from just seeing him in clinic, you'd never guess that was below the surface. For him, it was always there. But what really brought it out again was when he started to become sick. And when he had to interface with the medical system and when his kidneys were failing and he needed dialysis, that's what brought back all of those bad memories. And we hear this all the time. Other patients of ours who suffered a trauma and torture, it can be kind of random things that bring it back. One patient, when she had to wait in line at her oncology appointment, checking into the cancer hospital, it was the waiting in line and being in the kind of institutional setting that triggered her memory of her past experiences, and I think of food lines and things like that. So it's hard to tell. We never know what it is that brings those things right back to the surface, but oftentimes it's things in the medical setting and things when people start to become vulnerable again. All right, so other things we can do, resisting re-traumatization. We want to move forward. So we don't want to dwell and make people rehash all of their past, but we can reaffirm a patient's strength and just to recognize it's their strength and their resilience that has gotten them out of their past trauma and into where they are now. It's also helpful to educate patients on prognosis. So I will often liken trauma-related symptoms to be like a chronic disease, because some people kind of expect the past to be in the past, but to just let them know that it's like a chronic disease that like COPD, it's going to flare up from time to time, and it's going to be on the forefront of their mind, and it will really affect them. And there will be times where it's in the background and it's really not playing a part of their daily life, but this is kind of going to be with them in some way, probably forever, but that they can get things under better control than they may be now. It's also important, we talk to our patients, our refugee patients, about the triple trauma paradigm. As I'm sure many of you are familiar with, a lot of refugees think, okay, I made it, I'm in the US, this is the promised land, I finally got here, and I should be fine now. But to recognize that there's more than just the initial trauma that led them to leave their home country, the war or the persecution or whatever it was. So that's the first trauma. The second trauma of a refugee experience is the fleeing in the refugee camp. So a lot of uncertainty and waiting, and sometimes food scarcity, resource scarcity, separation from family. And then the third trauma is actually resettlement. So a lot of people expect once we made it here, everything's going to be smooth sailing. And as you know, it's not the case. People, when they arrive in the US as refugees, first they start out in debt because their flight to the US from their home country or from the refugee camp, they're given a travel loan and they have to pay that back. And then they're also expected to learn English and be working and self-sufficient in 8 months. So, forgetting all the things that happened in the past, that's a pretty tall order to be fully self-sufficient, kids in school, families working and moved on. On top of all of that pressure, there's a lot of, there's a whole system, a language to learn, medical care, and then so much lately, especially, it feels like anti-immigrant sentiment. So refugees, they finally made it here, and then they face racism and persecution and mistreatment here in the US, which is very sad. But so it's important to recognize and let people know, yeah, you made it here. Things might be harder before they get better, but it will get better. All right, so I hope we've covered the 4 objectives: realizing the impact of trauma, recognizing signs and symptoms, responding to that, and resisting re-traumatization. So I wanted to leave a lot of time for questions, comments, hear your experiences.
Hi, I have a question. I'm trying to turn on my video so you can see me. But okay. Hi, my name is Preet, and my question was, while we're talking about trauma-informed care in the perspective of providers giving it to the patients, but how do you handle it if, like, let's say you yourself have relatives or families, or you yourself have gone through some, traumatic event while you're also trying to help these patients?
Yeah, I think that's a really good question. This happens a lot, and especially, so our clinic is built for refugee care, and as a result, a lot of our staff are former refugees. And then we work closely with, they're interpreters, but they do more than just interpret. They do case management and cultural mediation. So they too have had their experience. So they're bringing in their own experiences and trauma, and it's mixing in with patient trauma. And I don't think there's an easy answer to that. I think a lot of it is awareness about how your own experience can be triggered, and how you can be personally re-traumatized by hearing about other people. I know for our cultural mediators, interpreters that I talked about, they actually meet with our clinic psychiatrist once a month just to debrief and talk about, all the secondary trauma that they have working with their difficult population. So thank you for bringing it up. I don't have an easy answer or solution, but just to recognize it's real, and secondary trauma is really important to be aware of, and then try to take care of yourself. So yeah, thank you.
Thank you.
I have a question. I've been kind of rotating on different clinical rotations, and I think one thing I've noticed is that we'll be part of a team and we'll see a patient, and I think the second that patient gets kind of labeled by the team as non-adherent or difficult, it's really hard to get rid of that label. And as a student who's not maybe like the final decision maker, who's seeing them every day but maybe not being able to like make the decisions, like how would you suggest us kind of breaking through that and getting through to our team?
Yeah, I think that's a great question. And I think you as a medical student have oftentimes the closest relationship and know those nuances of a patient's history better than anyone on the team. And I do think it's a unique opportunity really to having that closeness to be able to find out what are the reasons for the non-adherence and how can we work around that. Sometimes we can't, and sometimes these issues are bigger than just recognizing that there's some trauma and then now we can move on. A lot of trauma is bigger than that, and there's not an easy or pat answer that I can give, but sometimes it is things that we can do. Sometimes even just explaining, when someone has to go to interventional radiology for a procedure, but certain things are very triggering to them, like certain positions. Is there a way that we can reposition the patient so that it doesn't, re-traumatize them, or things like, I didn't put this photo in, but I have another photo of when we do central lines, we cover that patient from head to toe. They're like covered and this much of their neck is showing. And that can be really traumatizing. So is there a way we can do draping better, or a way we can, somehow make their comfort or their experience better? So there's those kind of things. If we find out that history, can we do something small to help them? For the case of a patient who's NPO and things get delayed and then NPO again and delayed, sometimes it can be helpful even just to let, I'm thinking like for endoscopy, this has happened multiple times, planning for an EGD, upper endoscopy in the morning, and then it gets bumped and it gets bumped. And sometimes there's nothing you can do, but sometimes letting the GI team know, hey, this person has had a really hard time of it and being NPO repeatedly, we think, they might just leave against medical advice. And so is there anything you can do to, keep them on this day, even if it gets bumped later, things like that. Yeah. Does that answer the question a little bit?
Yeah, absolutely. Thank you.
Yeah.
I guess like kind of along the same lines, like you mentioned the NPO thing. And like, there are situations like you mentioned where it's unavoidable for us to have to put patients on PO. And you mentioned kind of advocating for them to other teams. Is there anything else that we can do to support those patients? Like, would explaining it in a certain way help at all?
Mm-hmm. Yeah, I think in general, taking the extra time to explain things, it sounds very simplistic, but it's really not. I mean, all of you, I'm sure, have been in medical settings. There's such a time crunch. You have a lot of things you need to get done in a short amount of time, and so it's very easy to not, to just brush through and not fully explain things, and that's for the English-speaking literate patient. So you can only imagine how much harder it would be for a patient who English is not, they don't speak English. Maybe they are unfamiliar with Western medicine, and things that we take for granted as being the norm, or of course you would understand this, may not be the norm. So even the fact of needing labs every day, it's possible no one really explained what he needs labs for. And actually, I think that's probably more likely not done than it is done, that we're telling them, well, after a hip surgery, you can lose blood. And so this is important to make sure you have enough, blood, things like that. Rarely get explained, but can help in there, rather than just say, oh, patient refuses labs, to go the extra step and see what is it about the labs, or maybe we can do them later in the day. Maybe it's that phlebotomy comes in at 5 a.m. and that's why he was refusing. So yeah, taking the extra time to get down to the bottom of it can sometimes help.
I see a question in the chat. Could you talk a little bit about the structure of your clinic and the population that you serve?
Oh, sure. Yeah, I'd love to. So I am in Seattle. I'm at the University of Washington, and I actually did my residency here, and I started there as a resident. My continuity clinic in internal medicine was in the International Medicine Clinic, which is a clinic that is part of Harborview, so our county hospital, and our entire population is immigrants, and most of them are refugees. We also have a lot of asylum seekers. And so it's a small clinic that's designed entirely for refugee populations. I guess I would add to that too, just a part of the design I mentioned, we have a lot of staff who are multilingual and former refugees. We also have psychiatry on site, so it's built into the clinic to try to improve access. So there's not, there's enough stigma already in a lot of communities about psychiatric care. We don't want them to have to try to make an appointment in a different building or a different unfamiliar clinic. It's very much a medical home. Pre-pandemic, patients would come and hang out in the waiting room just to socialize with other patients, even though they didn't have appointments. We have a pharmacy on site and clinical pharmacists. We have actually an acupuncturist who's been volunteering once a week for decades, just completely free. He has his own practice, but comes to serve our patients. And then the cultural mediators and case managers in several languages: Somali, Amharic, Spanish, Vietnamese, Cambodian, and I'm sure I forgot one when I was listing, but yeah. But we love it. I stayed after residency, and that was probably 14 years ago now. I just read in the chat, I'm not sure if it's B, if that's how you say it, as a renal social worker, how triggering it is, or how difficult it is with dialysis. And I imagine this is something that you probably see in different ways coming out every day. I think dialysis, one of those huge life changes, or that just, it's a really difficult diagnosis for people, and especially aging population, aging refugee population, becoming suddenly very vulnerable again when they used to be very independent. So thank you for sharing that.
Dr. Aaron, for people who are interested in learning more and improving at trauma-informed care principles, do you have any recommendations for other resources or websites?
Yeah, there's a couple, oops, sorry. I'm not on screen share, right? I have a couple, I wrote down a couple websites to that I can put in the chat if I can get to them. So I'm not sure, have any of you heard of Ethnomed? It's a UW website that has information for kind of about cross-cultural medicine in a lot of arenas. So not just medicine, but other aspects of health. So I'm just looking for it now. So Ethnomed, we have some resources there, like we have patient videos and how to ask about trauma and how it can affect medical care. Hold on, I'll put that in the chat. So these are some more videos from patients, but there's other resources there. And then the other one I looked at was, I'll put here. This is, I have not gone through this, but when Leah, when you were asking me earlier about other resources, this one is through SAM-HSA put together a manual more about trauma-informed care. It's a whole manual, so I haven't read through it myself personally, but if someone were wanting to know more in detail, you could check that out. I think what you're doing, and I think being part of this forum, is already so much of the way, like the awareness and the wanting to help these patients who suffer trauma is already the majority of the battle won. So I think this is an awesome group, and I'm really glad that you're interested.
Great. Any last questions? Okay, I think we're good. Thank you so much, Dr. Aaron, for your time.
You're so welcome. Yeah.
And thank you everybody for coming.
Yeah, thank you for having me.